Hi, this is Dave Kirshner, and today we're talking DVT ultrasound. Now, as with some of the other videos I've put out, we're really going to be talking about how we do the study and what's the background for why we should be considering it in the first place. We're not going to get into too much of the data on, should it be 2-point or should it be entire leg? That's something we're going to save for another time. And I'll give you the summary right now. The summary is basically this. You want to, first of all, find the femoral vein, begin at the inguinal ligament, and end at Hunter's canal or the adductor canal. And then you want to wrap around the back of the leg, find your popliteal vein and the popliteal fossa. Begin where the popliteal vein is lateral to the popliteal artery and go down to the trifurcation. Now, the reason we do this study is simple. Things like leg pain, leg swelling, chest pain, and shortness of breath. Now, say for example, we had someone with DVT symptoms. Well, actually, let's say we had 100 people that had DVT symptoms. If we were to do scans on all 100 people, we're probably going to find DVTs in about a third of them. If we scan everybody else, well, we're going to find a definite diagnosis in probably another 11 to 18%. And then that middle group, well, we're going to be left scratching our heads because we didn't find an exact reason. Now, let's say, though, now we take those 33% that had the symptoms, and now we know that they definitely have a DVT. Well, out of that group there, about 50 to 60% of them are going to end up with a pulmonary embolism, and out of those PEs, only about 50% of them are going to be symptomatic. And if you really think about these numbers, that means that there is a whole other group of people that were at risk for PEs or who had PEs and you didn't even know it. And just to remind you, PE mortality is about 3 to 10%, and 10% of symptomatic PEs are going to be dead within the first hour. Now, I know what you're thinking. You're like, whoo, those are some pretty scary stats. I am glad I'm wearing my brown pants. And then your wife is like, well, those aren't brown pants. Those are actually gold leggings left over from when I went as Jim to my high school reunion. And then you're like, why do you always pick on my clothes? I feel comfy in them. And then she says, honey, I threw them out. Like, I literally remember throwing them in the garbage can like 3 weeks ago. And then there's that awkward silence that you totally always seem to find yourself in. And then you don't know what to do with it. Anyway, moving back, sometimes you can find an alternative diagnosis. And if you have someone with symptoms of DVT, some of the other alternative diagnoses you need to consider are cellulitis, lymphadenitis, edema, lymphedema, lymphoedema, Baker cysts, cankles, varicose veins, and of course arterial issues. Now, if we have all of these things, including DVTs, on our differential diagnosis, well, couldn't we just rely on the physical exam? I mean, why can't we go back to the JAMA series and just say, hey, does this person have a DVT? Well, you know what? We could look for things like this, but at the end of the day, we're really not good at almost every part of the physical exam. So that's why people made up rules such as the modified Wells criteria. What they were trying to do is say, okay, we know we're not good at the physical exam. Could we put our limited use of the physical exam together with a couple components of the history to get a better idea of who we need to worry about? This is the modified Wells criteria, which gets us into a likely or an unlikely category. Now, the next step that we usually use when we're thinking of DVT isn't jumping right to ultrasound. It's actually considering, well, can I just get a D-dimer? In this day and age, we're using high sensitivity D-dimers, and we can think of our pretest probability as being low, medium, or high. And how we get to that is usually by using something like a modified Wells score. Well, if the D-dimer is positive, it doesn't always help us. On the other hand, if we're using it for its sensitivity, in the right population, such as those with a low and medium risk, it can be quite helpful in ruling out a DVT. But let's say on the other hand, it's positive, or we already know that we're a high enough likelihood. What's the next step? Well, if you look at almost any algorithm, the next step is go towards compression ultrasound if it's feasible. Now, there are a couple things like body habitus and patient positioning, which are two factors that can make compression ultrasound infeasible. anti-feasible. Damn it. It just makes it non-feasible, okay, you guys? From there, that's when you go down the rest of these plans to decide what else you could do. Now, if we're thinking of ways that we can look for DVTs, there are really 3 types of studies. There are venograms, there's ultrasound, and there's impedance plethysmography. And I only think I'm pronouncing that correctly. And these are the 3 that people will consider. And these are the 3 that have been the most studied. Now, if we're considering the gold standard, well, that happens to be a venogram, which you don't see done really anywhere anymore. I can't even think of the last time that I saw one done. The great thing about them is that their sensitivity and specificity are 100%, period. The other great thing is that they're operator dependent. The downside, and the reason that we're not doing them as much, is that they're invasive. You can't have as many people actually trained to do them, and unfortunately, they cause DVTs in about 2 to 3% of the people that they're done in. So they have significant risks. Impedance plethysmography. Well, first of all, what in the world does that mean? And it's still really tough to nail this down. But basically, you're measuring the impedance across vessels and across limbs, and it is wonderful for academic centers and research, but really, we don't do it. So that means we're really left with ultrasound. Low cost, non-invasive, portable, and still really good sensitivities and specificities. So we're going to use ultrasound to look at the venous system of the lower extremity, starting at the femoral vessel and going all the way down to where it trifurcates in the popliteal fossa into the calf veins. Now, if you're going to get a comprehensive ultrasound done to rule out DVT, they're really going to do 4 things. They're going to look for augmentation, compression, color flow, Doppler flow, and they also are even going to look at flow within the IVC. We're not doing that. We are focusing on compression. And looking at all of the studies, this is really the way that you're telling if there's a clot there or not. The augmentation, color flow, Doppler flow, IVC flow are all suggestive, but it's really the lack of 100% compressibility that's telling you that there's something in the lumen. Okay, so we've decided we've got to do the scan. We know we're looking at the lower leg. We've already gone through our D-dimer or started to sort out our pretest probability. And so now we actually have to put the probe on the patient. So let's think that we're starting right up there in the groin. Well, if we think about our transducer placement, we're going to be using the linear probe. Let's begin by having it sit at the maximum depth. Let's keep it perpendicular to the skin. And we're going to try to keep it transverse to the long axis of the leg. And we're starting just below the inguinal ligament. This means that you might need to move a pannus if you're trying to get right up there. And if you still can't find where you're going, feel free to palpate for the femoral artery and start with your probe right over there. Now, here's a nice diagram of the veins of the leg. And we're going to go through, and I have a little animation to show where we're going to start, some of the bifurcations that we're going to see as vessels come in to become the common femoral vein, and the entire length that we need to scan. So really we're going to start proximally at the common femoral vein, and the first branch is going to be the greater saphenous, and then the deep femoral vein. And we can follow all the way down the leg into the popliteal vein and the popliteal fossa, where it trifurcates into the calf veins. We want to look with our ultrasound really every centimeter, but we want to make sure that we're at least hitting any branch point. So we want to hit right proximally here, where it's just the common femoral vein, a little bit lower where the saphenous is taking off medially, a little bit lower where the deep femoral vein is joining the femoral vein to become the common femoral, and down in the popliteal fossa where the 3 calf veins are coming up to become the popliteal vein. What's the process that we do? Well, we're going to compress, then we're going to relax, we're going to slide distally, and we're going to repeat the whole way down the leg. Now, I wanted to make a diagram to show what the orientation is going to look like on our screen. I know in this image here I have a right leg, but for this next diagram I'm going to move to the left, and we're going to move back and forth from right to left from time to time. We're going to have the patient possibly in reverse Trendelenburg. We're going to get that knee flexed and the hip flexed, and we're going to have that hip and external rotation. Be sure to drape the patient to protect any personal areas, and you may even need to prop the knee up with a pillow or a folded blanket underneath it just to keep them comfortable. Now, if we're right up high, just below the inguinal ligament, we should see the femoral vein medially and the femoral artery laterally. As we go a little more distally, we said what's going to happen is we're going to see the greater saphenous vein come off of the common femoral vein medially. As we slide even more distally, that greater saphenous vein is going to move more medially, and the common femoral artery is going to bifurcate into the superficial femoral artery, which is in the near field, and the deep femoral artery, which is going to be in the far field. We're going to come down even further or more distally, and what's going to happen is we are going to see where that common femoral vein now is the superficial femoral vein and the deep femoral vein. You may still be able to see a little bit of the greater saphenous vein medially. If you lose it by this point, it's not a big deal at all. As we keep coming down the leg, we're really just going to keep focusing on the superficial femoral artery and the superficial femoral vein. You should note that the vein is deep to, or in far field, to the artery. We're just going to keep coming down the leg in 1 centimeter increments, compressing, keep coming down in 1 centimeter increments and compressing, all the way until we get to the adductor canal, which is also called Hunter's canal. At this point, what we're going to do is we're going to go from a posterior approach, and usually, I shouldn't say usually, what should happen is that we should be starting high enough that we're seeing the popliteal vein lateral to the popliteal artery. As we slide distally, that vein is going to come into the near field, which means it's more posterior. And finally, we should see it trifurcate into the 3 calf veins. Once you see that trifurcation, you have hit the end of our study. Now that we've kind of looked at that as a diagram, feel free to go back and review this little animation. But just to remind you again, this is showing the course with the bifurcations that we're looking for. Now that we're starting to get a mental image in our heads, let's go and let's look at how some of those areas look on ultrasound. Now, we're going to be back to looking at a right leg again for these next images. So the vein is going to be to screen right, and the artery is going to be to screen left. So in this picture, I'll tell you, we have the common femoral vein, and we have the common femoral artery. Deep to them, we have the psoas muscle. Because we only have the common femoral artery and the common femoral vein, I know that we are quite high up near that inguinal ligament. And this is what they look like. Now, you're probably already noticing that there's something moving here within the common femoral vein, and that is one of the valves that you'll sometimes see. I just wanted to point out that, again, there's one vein and there's one artery. In this case, I wasn't compressing anything. If we go a little more distally, again, we're going to start with a common femoral vein and the common femoral artery, and I'm going to slide distally, and you're going to see how the greater saphenous vein comes off the common femoral artery. How the greater saphenous vein comes off the common femoral vein, and how the common femoral artery bifurcates. Wait for it. There it is. So we can see now we have the superficial femoral artery and the deep femoral artery. And over here we still have the common femoral vein with the greater saphenous vein having come off of it medially. We can just watch that again without any of those words there, and you can see how they move as we go distally. This is one on the left side. This is again looking at the takeoff of the greater saphenous vein. We have the greater saphenous vein here, the common femoral vein, and the common femoral artery. In this case, I am compressing, and you can see that the common femoral vein and the greater saphenous vein compress entirely. There is no clot there within the lumen. We're going to move back to the right side again. In this case, we still have the common femoral vein, the superficial femoral artery, and the deep femoral artery, and we're going to slide again a little more distally to see now how the common femoral vein becomes the superficial femoral vein and the deep femoral vein. You can see it's one, and now it's just split into two. I'm a little off axis, so I need to bring it back medially. And we have the superficial femoral vein and the deep femoral vein. And we still have the superficial femoral artery in view here. So watch again and see if you can catch when it splits from being the one common femoral vein into the superficial and the deep. As we go even more distally, we are just going to be following that superficial femoral vein and the superficial femoral artery. The superficial femoral artery is going to be superficial or near field to the vein. And what you're seeing now is me just compressing, moving down a centimeter, compressing, relaxing, moving down a centimeter, compressing, relaxing, moving down a centimeter. As you can guess, we use a lot of gel for this scan. As you come more distally, the veins are going to course medially as you get near the distal femur. Okay, so we've talked about going from proximal to distal along the thigh. Now we need to wrap around and we need to move to the popliteal region. When we're in the popliteal region, we have a couple options to get the patient comfortable to be able to do this scan. So, first of all, we could just have the patient roll onto their side. Secondly, we could have them sitting with their legs hanging over the bed, moving a little bit forward so that we can reach the probe behind their knee. Or we could also have them on their back with their legs bent. If you have their legs too bent at times, what can happen is that the semitendinosus and semimembranosus, or the hamstrings, can get in the way, and your probe can want to roll off to the side. Just be cognizant of that and be aware that you might need to extend or flex their leg a bit just so that as you're compressing, things aren't moving off. If we're to look from a posterior view, I'll tell you we have the popliteal vein here, the popliteal artery, and here actually we have the sciatic nerve. We're going to see as we slide from proximal to distal, the popliteal vein is going to start lateral to the artery, and then it's going to come more superficially. You might also notice that the sciatic nerve bifurcates at one point as well. Now it's superficial, and now it's even wrapping a little to the other side. Here's another view. Again, this one's already labeled. In this case, the vein is not collapsing completely, even with good compression. So there's a strong suggestion that there is clot within the lumen. Again, we're starting where the popliteal vein is lateral to the popliteal artery, following it until the vein is superficial or in the near field to the artery, and then following it down until it trifurcates. And this is what the trifurcation can look like. We'll have the popliteal artery in the far field, and we have the three branches, or what will be the three calf veins, in the near field. And with compression, you can see them all compress. Now I'm sliding proximately to it just being the one popliteal vein. Now I will tell you that I have never had an image this good again, so I had to use this one. Oftentimes when they branch, one will be quite a bit bigger than the others, or they'll dart off in different directions quite quickly. So don't be surprised if it doesn't look like this perfect four-leaf clover. Now in terms of a positive DVT study, really what we're looking for is failure of the vein to collapse completely. If you are putting so much pressure that you're starting to distort the artery, you've put enough pressure, and if that vein isn't collapsing, then be very suspicious that there's clot there. It's not about seeing if there's something echogenic, it's really about making sure that you can collapse that vein 100%. In terms of a couple tips in that regard, I mentioned that in the popliteal area, the hamstrings might be getting in the way. But even as you're sliding down along the thigh, it might be hard in a patient with a bigger leg to really get that compression. If I could suggest just having your other hand behind the patient's leg, this will help you keep the leg stabilized, and then you can either still press down with the probe, or you can use that hand to kind of bring the leg up to the probe. Anything you can do to make sure that you've kept the probe perpendicular, you've kept it over the vein, and you've been able to give enough pressure to collapse it completely. Okay, so those are some tips. We've looked at a lot of negatives. Let's look at a couple positives for now. This is at the point quite high up, and in this case, we have some clot within the common femoral vein. This is a right leg. We can see the common femoral artery just to screen left, and we can see that there's some echogenic clot within the common femoral vein. Even if we didn't see it, the fact that we can't compress tells us that there's something within the lumen clot. Now, how about this one? So my first thought for you is, which leg do you think this is? And the reason it can be confusing is that the takeoff of the saphenous in this case isn't where we'd normally expect it. That being said, we always expect the artery to be lateral to the vein. So this would be a right leg. There is the non-compressible femoral artery. There is the common femoral vein, which is also not compressible because it has some non-obstructing mobile clot within it. The saphenous vein in this case is taking off of the common femoral vein laterally, and then if we followed it down, it would actually wrap more medially as it goes down. And right there again is the clot that we see. In this case, do you think it's right leg or left leg? Well, this is a left leg this time. We have the common femoral artery in the near field and the common femoral vein just deep to it. And again, even with good compression, and we can actually see that there's a little bit of clot in there, but we're not getting 100% occlusion. Some clot will be more echogenic than other, which is why we don't use it as one of the criteria. Again, we are just looking for 100% compressibility. Sometimes it will be partially echogenic, like in this one around the outer rim. In this case, this is a right leg. This is the common femoral vein, and you can just see a little bit of the takeoff of the saphenous in the near field on the right side of the screen. The common femoral artery has already bifurcated into the superficial and the deep branches. Now, I know I mentioned compressibility. And the reason why, again, is because sometimes you'll see something in a vein that you might think, well, maybe that's clot, but if it's still compressible, it doesn't matter. In this case, again here, we're seeing a valve. This is actually a valve fluttering back and forth. I've turned the probe into the long axis, and I'm seeing the takeoff of the saphenous vein from the common femoral vein. Again, don't be thrown off by these things. Don't be distracted. Again, you're looking for 100% compressibility. If we move down to the popliteal area, in this case we have compression, and then no compression. We have compression, no compression. Even in that first compression right here, it might not be compressing 100%. I'm going to point out just with this video why I like always taking clips. It could be that you don't catch this again, or it could also be that you dislodge this clot. That's why we want to be recording our scans too, so that maybe you're only going to catch it once. But also, if you see clot, we don't want to be pressing on this 50 times, and we also, bless their hearts, don't want to be getting every resident and med student to be looking at it, because we know that there is a real risk that we could dislodge some of this, and it goes up and becomes that 50 to 60% that get PEs. This is another popliteal one. Ooh, tricky. What do you think here? Oh, I can see a small artery. That's pulsatile. Oh, and we have two veins, one vein on either side that are compressing. So is that positive or negative? Well, this one is actually positive. Those are superficial vessels that we're seeing. If you look a little deeper, you can see the big pulsatile popliteal artery, and superficial to it is a popliteal vein that is not compressing. If we look at it from a little different angle, this is the same one here. And again, you can see the artery that's pulsatile, and now it's actually compressed or distorted with the pressure, but the vein is still not completely occluded. Pitfalls with this, well, you could have poorly compressible veins. You could have chronic DVTs. You could have echogenic lumens just because there's low flow states. Baker cysts are another thing that can be confused for them. You could erroneously look at superficial vessels instead of the deep vessels, or just having inflamed lymph nodes. Again, having a standard approach and knowing your anatomy is going to help you avoid these pitfalls. On this note, I just wanted to show you a couple examples of Baker cysts. On screen left here is a Baker cyst. This one is a simple Baker cyst. If you were to slide down, you'll see it has a beginning and an end. If we were to put color flow on it, it doesn't have any color flow within it, and it's not continuous with any vessel. On screen right, on the other hand, this was a gentleman who had a Baker cyst, who actually also had a supratherapeutic INR, and he had some trauma to his leg. So he actually has a Baker cyst, which now has blood collected within it. If you were to follow this proximally and distally, you'd see that it is not contiguous with any venous system, and it's not even located in the right spot in relation to the popliteal artery. So again, in summary, we want to assess that entire femoral vein. You want to start at the inguinal ligament and end at the Hunter's Canal for now. In terms of the popliteal vein, we're going to begin in the popliteal fossa when they're next to each other, and we want to end at the trifurcation. So that's it for now. We're going to talk about a couple other things when we meet together. I realize I didn't get into more of the recent data on how we should be supporting this, but again, we'll talk about that when we get together. Thank you.